All right. So, hello, assalamu alaikum, and good evening. My name is Dr. Zaib Qureshi, and today we are going to discuss the recurrent miscarriages, how to manage, and together we are going to dig out that what are the risk factors, what are going to be the treatment modalities, and how this session is going to bring the change in our, the current practice as well. So I will try to give the best evidence-based knowledge according to my, the own personal knowledge, and which is going to be based on evidence-based guidelines and all. And if you guys have any question, you can ask me in the middle as well, or even in the end of the session as well. So, I mean, that is going to be, the good if it is going to be more interactive rather than you guys just are going to listen to me or just are going to absorb. All right. So the learning should be a two-way process. So if you really think that you have any question, or if you want to ask, from any of us, because almost, all of us are, the practicing OBG. So of course, you guys can raise your hand, you guys can write in the chat box, and even, you guys can, the ask in the middle or in the end as well. Okay. So let's get started with what is recurrent miscarriages. So as we are familiar with that, how we are going to study something. So of course, we need to start from the basic, isn't it? So we are going to start from the basic as well. First of all, we need to understand the definition of recurrent miscarriage. How many of you are aware of the definition of miscarriage? Because this is going to be a very sensitive topic, isn't it? So being a practitioner or being a woman, or the dealing with so many women, so of course we do deal with recurrent miscarriages on daily basis as well, isn't it? So first of all, we need to understand that how we are going to the define. So first of all, we are going to define that miscarriage is defined as, first of all, as the loss of an intrauterine pregnancy before 24 weeks of gestation. All right. So this is a very generic definition of miscarriage. Then WHO defines expulsion of a fetus or embryo which weighs 500 gram or less, and the gestational limit is less than 22 completed weeks of pregnancy. So, however, the implication of both definitions are going to be according to our the needs, whether it is clinical. Are we going to use this WHO the definition, or theoretically, if we are going for an exam, of course, so then we have to take this definition, right? Because this is from RCOG guideline. Then miscarriages can be classified as two: early miscarriages and late miscarriages. Early, when pregnancy loss occurs less than 12 weeks of gestation, which is going to be first trimester. Although, however, if we take, the days, so of course we are going to count them as 13 weeks to be precise. All right. So less than 12 weeks of gestation, this is going to be the early miscarriage, and then late miscarriage, when pregnancy loss occurs between 12 and 24 weeks of gestation, which is going to be second trimester miscarriages. All right. So basically, we are going to classify miscarriage into early or late miscarriage. Then, then comes, what is the definition of recurrent miscarriage? That was a background knowledge of miscarriage, isn't it? So let's define that what is recurrent miscarriages. Now we do have, the different definitions of recurrent miscarriages according to so many guidelines around. All right. So we are dealing with Royal College of RCOG, okay, RCOG guideline UK. We are going to talk about, the ASRM guidelines as well, okay, advanced sexual and reproductive medicine. Then we are going to talk about the European guideline. So RCOG 2011 says that the pregnancy means all pregnancy losses that are not further defined, and they are taking 24 weeks of gestation, and they are taking 3 consecutive miscarriages. Please bear with me and feel the difference, because sometimes even in the theoretical knowledge, and sometimes even in clinical practice as well, if we have to take the any of the management modality from either of the guideline, because we do follow couple of guidelines. So of course, if we are talking about RCOG guideline, then all pregnancy losses that are not further defined, those are up to 24 weeks of gestation, 3 consecutive miscarriages. All right. It's not like one miscarriage, one live issue, then one miscarriage, and then another. No, it has to be 3 consecutive. Then comes ASRM. ASRM says that the clinical pregnancy defined by ultrasound and histological examination. Mhm. Ultrasound or histological examination only mentions that maturity is lost prior to 10 weeks. Mhm. Interesting, isn't it? We have never heard of this. Like prior to 10th week only. And they are taking 2 consecutive miscarriages as well. 2 consecutive miscarriages, and the losses are prior to 10th week of gestation. Then European guideline 2017 says that, see, feel the difference. Yeah. So serum or urinary HCG positive, it can be ectopic or molar, means they are just dealing with the pregnancy. They are not dealing with the outcome. Because the what is the outcome of pregnancy? It can be a healthy pregnancy, it can be a miscarriage, it can be ectopic pregnancy, it can be molar pregnancy as well, isn't it? So all of these are going to be, either confirmed by serum or urinary beta HCG. It can be plus ectopic, it can be molar, which is not included in definition. All right, so they are not taking, the ectopic molar pregnancies in this definition, of course. All right, they are taking gestational age again up to 24 weeks, and they are taking 2 consecutive or non-consecutive miscarriages. This is the biggest difference. All right, are you with me? Is it clear up till now? So we are going to say that according to the Royal College of RCOG UK, that the loss of 3 or more consecutive pregnancies, and it usually affects up to 1% of the couples which are trying to conceive, and 1 to 2% of the second trimester pregnancies miscarry before 24 weeks of gestation. See, although the prevalence is very less, 1%, but we do see it in more than 1%. All right, then we are going to talk about the different risk factors, of course. So let's make it clear again. Loss of 3 or more, the miscarriages. All right, loss of 3 or more miscarriages, which is affecting 1% of the couples trying to conceive, and 1 to 2% of the second trimester miscarriages, pregnancies will miscarry before 24 weeks of gestation. All right, are you guys with me? Is it clear, Sandhya? Nayab, is it clear? Uh-huh. All right, very good. Great. All right. So we are on clear on definition of miscarriage. We are clear on the definition of recurrent miscarriage. Okay. Because we do deal with this RCOG guidelines moreover. Okay. So we are going to keep, but still, we need to understand, and we need to know how world is evolving and what type of guidelines we are following in terms of, the miscarriages and recurrent miscarriages. All right. Okay, now let's talk about the factors. All right. So there are going to be multiple factors, which are going to be like, kind of, the affecting the pregnancy loss. All right. So let's take one by one, and then we are going to discuss all of these risk factors accordingly. All right. So let's see. First we are going to take, kindly mute yourself, everyone. Okay. So we are going to have less interruption, and we are going to have a clarity of our topic. All right. So factors, let's take one by one. The first factor is alcohol. The effect on risk of pregnancy loss is not evidence-based as direct cause of the recurrent pregnancy loss, but sometimes it is sensible to avoid excessive intake. All right. It is sensible to avoid excessive intake. All right. According to new NICE guideline on management of the antenatal care of pregnancy, they say no amount of alcohol is permissible for any healthy pregnancy. All right. Earlier they used to say that, okay, they can take alcohol, but in less amount. All right. But according to the new guideline 2021, they say that no amount of alcohol is permissible for pregnancy. However, they say in recurrent miscarriages that yes, it is better to avoid excessive intake. All right. It is better to avoid excessive intake. Then comes caffeine. Caffeine has no evidence as direct cause of recurrent pregnancy loss. However, again, it is sensible to avoid excessive intake. All right. Then how about exercise? And how many of, if we talk about our population, how many of our women, they really do exercises in terms of exercises, not the household chores on daily basis or no. All right. So exercises mean high intensity occupational activity poses a risk. So it means the additional note is going to be the sensible exercise level is encouraged, means the healthy one, not the excessive one. what will happen with the excessive one? If somebody is a marathon runner, if somebody is a kind of the heavy exercise, she does very heavy exercises in terms of weightlifting or in terms of the bodybuilding. So what do you think could be the effect on the fertility? Because it is going to block the GnRH, okay, from hypothalamus, which is in turn going to block the LHF receptor. So in turn, what will happen? There is not going to be any ovulation. So the heavy exercise, marathon runner, weightlifting, anything which is going to excessively increase or decrease the weight is going to affect the release of GnRH from hypothalamus. All right. So it can lead to hypothalamic amenorrhea. So this is going to affect the fertility in turn. All right. So high intensity, when of course, in terms of recurrent pregnancy loss after amenorrhea, what will happen is that, it is going to pose some kind of activity as well. Sometimes ovulation will happen. Sometimes it is not going to happen. Sometimes, it is going to cause other, the health disasters as well. Then comes family history of pregnancy loss. Do you really think that family history is going to be important in pregnancy or miscarriage? Yes or no? No, right? Because miscarriage is personal. It is not going to bring any kind of family association. So for this, they say that the women who miscarry are more likely to have a family history of pregnancy loss. However, further research is still needed. So they're not sure about it yet, that whether it is the associated or no. Okay, so it can be, because it can bring about the stress level, it can bring about the anxiety that can affect again prolactin level. Again, prolactin level can inhibit LHF research and can again the do certain problems with the ovulation and all. Then comes maternal age. Yeah, maternal age, very important risk factor, isn't it? Because what happens with maternal age is, because the risk will increase as age will advance. So advancing age is going to be associated with chromosomal abnormalities. Chromosomal abnormalities, which one? Aneuploid pregnancy loss number specifically increase. So what are aneuploidy? Aneuploid means addition of additional chromosome. And what are those, the aneuploidies we do see? Any example, anyone? Any example? Aneuploidy. Down syndrome, isn't it? Edwards syndrome, Tau syndrome, okay? Or it can be the loss of, the sex chromosome, Turner syndrome as well. All right. So aneuploidy can occur with advancing gestational age, which can lead to recurrent pregnancy loss as well. Then comes occupational environmental exposure. They say there is no evidence as direct cause of recurrent pregnancy loss. However, you have to avoid exposure to possible hazardous substances during pregnancy. All right. Yeah, trisomy or monosomy. Very good, Dr. Shams. All right. So basically, aneuploidy, either addition or either subtraction, right? So paternal age, what do you think is going to be the reason for the age of the father? Is it going to affect any loss? Yes, it is. Okay, it is. So it is a kind of misconception in our society that, okay, the male is not going to the cause any kind of the problem in terms of the congenital malformations or something. Okay, but paternal age is going to, the risk is going to increase in advanced paternal age significantly after the age of 40. Okay, but yes, it has less pronounced effect than maternal age. Okay, so can anybody tell me, or anybody has come across with, that is there any kind of congenital malformation which is associated with advanced paternal age? Anyone? Yes, sure, Dr. Shams, I will do that. Okay, no problem. Any idea about, what can happen with advanced paternal age? We are talking about, if the age is more than 40, so is it going to cause any kind of congenital malformation to the baby? Yes, it can. So the literature, our book says that achondroplasia, that can happen with advanced paternal age. If you guys want to write it down or note it down, you can do that. All right. So achondroplasia can occur. All right. Then previous pregnancy loss. Of course, we are talking about recurrence pregnancy loss. So it will increase with the number of previous pregnancy losses. So our the additional note is going to be percentage of pregnancy losses with euploidy increases Means with previous pregnancy losses, the percentage of pregnancy losses with euploidy means the normal one, it is going to increase as well. All right. So this is a very important factor to note down. So how about smoking? Smoking itself has no evidence on direct cause of recurrent pregnancy loss. However, it is associated with poor obstetric outcome if either partner smokes. Either partner. Interesting, isn't it? So earlier we used to say that active smoking is bad, but now passive smoking is also bad. All right. Plus, because if the partner is a excessive smoker, so what can happen is that it can derange certain the sperm parameters as well, oxidative damage, cellular, the damage of any the formation spermatogenesis defect. So there can be the if whatsoever that happens, fertilization occurs, the pregnancy occurs, but yes, chances of the things are going to be worse with that. Okay, so if pregnancy is going to be there, then yes, with this the smoking, the pregnancy adverse pregnancy outcome can also happen. Okay, there can be small for gestational age, there can be the preeclampsia, although some says that it can be effective, it can be protective for preeclampsia. Okay, then there can be defective placentation. If there is defective placentation, what can happen, that there can be with defective placentation we do see few things. We do see the intrauterine growth restriction, we do see early onset preeclampsia, we do see early onset IUGR, we do see the premature separation of placenta, normally seated placenta, which is abruption. All right, so three adverse placental outcome can they happen with the defective placentation. Okay, then what about stress? However, they say that there is no evidence as direct cause of the recurrent pregnancy loss. However, recurrent pregnancy loss can cause significant stress. See, it is proportionately associated with each other. Because if a woman is the stress, or if a woman is having the consecutive miscarriages, so of course it will increase the significant amount of stress. So what can happen with this stress, guys? It will increase the prolactin level, and in turn prolactin will come into action, and it is going to cause further problems later on. All right. So yes, stress factor is there. That's why with after every loss, doesn't matter miscarriage, we do need to have the proper counseling. We do need to offer bereavement counseling as well. So as a practitioner, as a clinician, always remember that we have to give additional 15 to 20 minutes to each such woman who is experiencing such the bad, adverse, or poor obstetrical outcome. Okay, starting from miscarriage to the IUFT or whatsoever. All right, because if we are not giving support, enough support in that particular period, which is very vulnerable, so of course woman is going to be more in the stress, and later on she can come across with multiple problems. All right, then what about weight and BMI? So the risk will increase as BMI will increase above 25, but evidence from assisted reproductive treatment. So it will affect the ART treatment. However, how many of you do really think that the BMI is very important for the fertility, even if we are not the working in a IVF center or the ART centers? Yes, it is, because the increased BMI is going to be again associated with so many problems. All right, isn't it? So it is going to be associated with so many problems as well. No, sweetheart, not tubal blockage directly. Okay, weight is not going to be associated with tubal blockage. Weight is going to be associated with ovulation. Okay, because sometimes what can happen is that increased BMI can be associated with polycystic ovarian syndrome. All right, so polycystic ovarian syndrome is going to be associated with what? Anovulation. All right, so if there is anovulation, if there is again this is going to be a vicious circle. All right, this is going to be a vicious circle. So always remember, whenever you see a high BMI woman in your clinic, all right, always try to dig out whether is she having any kind of the symptoms of polycystic ovary or not. All right, so basically even if we are not having so many resources, all right, we don't have any the transvaginal scan facility, or we don't have enough experts who are going to give us complete picture of the polycystic ovary, because we have to diagnose polycystic ovarian syndrome. On the basis of clinical picture, what can be the clinical picture? Number one, weight. Number two, acne. Number two, hirsutism. All right, there is going to be obesity, but there is going to be what? The weight to hip, the waist to hip ratio is going to be increased. So we need to see that. So this is a clinical tip, guys. If you are in low resource, the clinic, if you really think that your patients cannot afford transvaginal scan, or they cannot afford, the hyperandrogenic studies, okay, from the laboratory. So this is going to be a very useful clinical tip to all of you, okay. If they are, in the veil, parda, so you are just going to ask them politely, okay, can you just please show me your face and the neck, all right? So just try to find out that are they having, the signs of hirsutism or no? Excessive hairs on upper lips, excessive hairs on male pattern, the darkest one, black one. All right. So you are going to look at them, and then you are going to look at, even you are going to ask them that, the signs of hyperprolactinemia. Don't pinch the nipples unnecessarily. Just ask them first. If you really think that they are giving you history, then yes, you can do that, but gently. All right. Two things. Third, have an inch tape with you in your, the drawer all the time. Take a drawer, take the inch tape if you really think that a woman is having, the waist to hip ratio. So if it is more than 80 centimeter, more than 80 centimeter, so this is going to be a high probability that this lady is suffering from polycystic ovarian syndrome. This is characteristically for low resource, the OPD or the clinics, or if we are catering a very, the population in which we cannot bring about so many hyperandrogenic studies. All right. So polycystic ovary is a different topic. So this is just a clinical tip because we are talking about recurrent pregnancy loss. Because what will happen in polycystic ovary anovulation? Anovulation can lead to, the multiple problems. Okay. Not only, the polycystic ovary, if a woman is conceiving, so of course the chances of miscarriages are high in that woman as well. All right. Okay. So now we are going to, divide our, the factors into explained factors, which can be explained through our, the clinical scenarios, through our, the diagnosis, through our laboratory, or, the anything, which are explained causes. And some of them can be unexplained. Doesn't matter, what we do. So what can happen is that, the explained causes, what can be those? Genetic factors. All right. Genetic factors can be explained. Okay, it can be paternal, it can be cytogenetic as well. Cytogenetic, when we are going to take the product of conception of third consecutive miscarriage and we are going to send it for histopathology. And if histopathology confirms that yes, this has, any kind of chromosomal defect, chromosomal aberration, so yeah, that is going to be explainable cause. Then anatomical factors, we are going to talk about anatomical factors as well. What about body? Body mean uterine body. All right. And you can take it as a, the body as a whole as well for the female. Yeah. Starting from BMI, starting from body habitat, starting from, the uterus and the cavity of the uterus as well. Then comes cervix. Then we are going to talk about the cervical length as well. Then comes endocrine factors. Some of the endocrine factors can be there as well. Okay, however, it can be plus, it can be minus. We cannot, say that yes, this is a very, the most likely definable cause of the recurrent pregnancy loss. All right. Then we are going to say the immune factors. Yes, autoimmune risk factors, antiphospholipid antibody syndrome. We are going to talk about in depth for this because I really want you guys to focus on this because this is most commonly neglected, the thing in our, the society, in our culture. So unexplained causes could be infective, no reason. Environmental, plus minus could be or could not be. So it is still unexplained. Inherited thrombophilic defect. However, it could be most commonly cause of second trimester miscarriage, not the recurrent pregnancy loss. Bacterial vaginosis, no. Bacterial vaginosis, no, because bacterial vaginosis is a cause of cervical weakness that can cause second trimester loss, but not the recurrent pregnancy loss. Okay, so now let's take, the factors that are leading to, the recurrent miscarriages one by one, and let's deal with them. Okay, so what about risk factors? Maternal age. So we have just said that the advanced maternal age is associated with a decline in both the number and quality of the remaining oocyte. Makes sense, isn't it? Then The risk of miscarriage is highest among couple with the woman is more than or equal to 35 years of age and the man is more than or equal to 40 years of age. So yeah, we have discussed it earlier. Then comes the number of previous miscarriages as well. The risk of further miscarriage increases after each successive pregnancy loss, which reaches approximately 40% after 3 consecutive pregnancy losses. You can see that we have just said earlier in our opening statement that what was the prevalence of recurrent pregnancy loss? Only 1%. So with each successive pregnancy loss, point to be noted, everybody. Okay, so with each successive pregnancy loss, the chance of it is going to be even further high. So we need to be very careful. We need to dig out the cause. We should not let any woman go beyond 3 successive, the consecutive pregnancy losses. Then antiphospholipid antibody syndrome. It is the most important treatable cause. Like I said earlier, that yes, we need to pick this thing properly and we have to treat it. So this is the most important treatable cause of the recurrent miscarriage. Then parental chromosomal rearrangements, very important risk factor. Okay, so now this is what I want you guys to focus on. You know, we so much talk about maternal age and the risk of miscarriages as well. All right, so the risk of miscarriage, we can say that it could be one-off event, that any woman who's pregnant is at risk of having miscarriage. Okay, and that is about 1 in 4. So we can say, okay, 25% chance is there for every pregnancy there is. But with the maternal age, every age has its own rate of miscarriage. If we take 12 to 19, the teenager, 13%, 20 to 24, 11%. See, decreasing. 25 to 29%. Again, this is the best reproductive, the outcome age. 30 to 34%, again 15%. That's why we say that this is the best reproductive outcome age, right? 35 to 39 years, it is going to be 25%. 40 to 44%, 51% means that, if they are conceiving on their own, so the chances of miscarriages are even 1 in 2, 50%. Every 1 in 2 women will miscarry, most likely, not all. So more than or equal to 45, almost 93% of the women will miscarry. So can you see from this slide only that yes, this looks, a very, very fine and very good, the reproductive age for good reproductive outcome as well. So in terms of if we are talking about recurrent miscarriages losses, so of course we need to think of, the age, and then of course we are going to talk about the most common cause of the first trimester miscarriage, which is of course chromosomal aberration, chromosomal abnormality. All right. So if we are going to talk about that, so that is going to be a separate topic. All right. So in terms of this, the recurrent pregnancy loss. So yeah, maternal age is going to be very important risk factor. Okay, so this is what I want all of you guys to focus on: antiphospholipid antibody syndrome. All right. So antiphospholipid antibody syndrome. So what is happening in this is that yeah, first of all we need to understand again what is the pathophysiology. So APLS refers to the association between antiphospholipid antibodies, because we are talking about antibodies. Lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein 1 antibody, and adverse pregnancy outcome and vascular thrombosis. So where is this vascular thrombosis happening? Can anybody tell me? Where is this vascular thrombosis is happening if we are talking about in terms of pregnancy? Placental bed, isn't it? This is what we have discussed earlier. This is what I have told you guys earlier, that yeah, we are talking about vascular bed in the placenta, which is going to be a connection between the developing fetus and the mother as well. All right. So if there is any kind of problem at the level of placenta, so of course it will bring about, the adverse pregnancy outcome. So usually in APLS, what does antiphospholipid antibodies does? They will work on endothelial cells, monocytes, platelets. They are going to express of adhesion molecules, upregulation of tissue factors production, and upregulation of tissue factor production monocytes again, and it is going to express of glycoprotein 2b3A level at the vascular level. So usually it is going to bring about the thrombogenic state. Plus, the interaction with the coagulation regulatory protein, which is protein C, prothrombin, plasmin, and with the the deficiency, with the problem in any of these the antibodies like this, so what will happen is there is going to be down regulation, there is going to be the problem at the level of vessel. Okay, so what will happen is the chances of thrombosis is going to be high. And what that thrombus can do is the thrombus can get lodged anywhere in the vascular system. It will hamper the circulation. So what will happen? If we are particularly talking about placenta and the the developing fetus, so what will happen is no nutrient will transfer from the mother to the baby. Nothing, no waste will transfer back from the fetus to the mother as well, because that is the the function of placenta, isn't it? Right? So nutrients, the hormones and the the anions, cations, everything is going to be transferred, which is important for the developing fetus. And every the waste material is going to be transferred back from the fetus to the mother. So what will happen is that there is a clot, so there is no free flow. Okay, so what will happen in that scenario? So it will happen, it will bring about the adverse pregnancy outcome. So if a lady is having antiphospholipid antibody syndrome, so what can happen in the end is there is going to be 3 or more consecutive miscarriages before 10 weeks of gestation, plus 1 or more morphologically normal fetal loss after the 10th week of gestation. Right? And don't we ask, from somebody, if somebody is coming to us that, the doctor Saab, my one of the baby, the got miscarried and this and that. So sometimes we do ask, the baby normal tha, baby दिखने में सही था, आपने देखा था बच्चा, किसी और ने बच्चा देखा था, वो ठीक था, right? So this is a very important question to ask, because if it is a congenitally malformed fetus, the chances are high that okay, that could not be the antiphospholipid antibody syndrome, but that could be the chromosomal or genetic problem. All right. So for antiphospholipid antibody syndrome, it should be morphologically normal fetals. Okay, then there is going to be 1 or more preterm birth before the 34 weeks of gestation, which is going to be because of placental diseases. And what are 3 placental diseases we have just discussed? Early onset IUGR, okay, early onset preeclampsia toxemia, early onset abruption. I'm sure we all are well versed of all these terms. All right. So always remember, guys, if you really see that in your setting, in your clinics, that you do see there can be chances of antiphospholipid antibody syndrome, don't hesitate. Don't hesitate to go for this antiphospholipid antibody profile. Either you can write antiphospholipid antibody profile, because or you can write the categorically lipase anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein. If one test is positive, so what you will do, you will repeat the same test after 12 weeks. Okay, because if the 2 tests are positive for the same, from the same laboratory, okay, it should be the same laboratory again. All right, so the first test at 0 contact, and then after 12 weeks you have to repeat it. And if you really think that the titer is increased, especially this anti-beta 2 glycoprotein 1 antibody, so yeah, you are going to label this lady with antiphospholipid antibody syndrome. And then we are going to see in the next upcoming slide that how we are going to deal with these women. Is it clear so far, guys? Are you guys with me? Yes or no? Okay, great. Thank you. Thank you. All right. All right. Great. Okay. All right. Brilliant. All right. So let's go ahead. So we are going to talk about antiphospholipid antibodies. Like I have said earlier, that yes, antiphospholipid antibodies are going to be present. So we do see antiphospholipid antibodies are present in the woman with recurrent miscarriages for about 15% of cases. The prevalence of antibodies, women with a low risk obstetrical history, is less than 2%. Low risk obstetrical history means she has never had any 3 recurrent miscarriages, she has never had any bad pregnancy outcome, she has never had any history of low birth weight, IUGR, preeclampsia, and abruption as well. All right, but yes, there is going to be chance, which is going to be less than 2% only. Okay, live birth rate in pregnancies with no intervention is 10%. You can see that it is interesting. Sometimes what can happen is maybe thrombus is not that big, maybe it got flushed by anything, maybe, the nature really wanted to give any alive issue. So yeah, live birth rate could be 10% in this, without any pharmacological intervention, because we are talking about clot, you know, coagulation. Now we have to give few things to dissolve this clot, and we are going to talk about it. So this was, the antiphospholipid antibody syndrome, which is very important risk factor in the recurrent pregnancy loss. Let's discuss genetic factors, because this is also most commonly overlooked. The factors in terms of, when we see women with recurrent pregnancy losses. So yeah, in approximately 2 to 5% of the couples with recurrent miscarriages, one of the partners carry a balanced structural chromosomal abnormality. Balanced. All right. And the most commonly, a balanced reciprocal or Robertsonian translocation is going to be there, which is going to be associated with, again, Down syndrome. So we have said earlier that yes, aneuploidy risk is going to be increased. So chromosomal abnormalities of the embryo accounts for 30 to 57% of the further miscarriage. See, further miscarriage. The risk of miscarriage resulting from chromosomal abnormalities of the embryo increases with advanced maternal age. And this we have discussed earlier as well. Now you guys can relate that how things are working. Okay, synchronously, how things are working with each other. Advanced maternal age is going to increase the chromosomal abnormality. Chromosomal abnormality will lead to recurrent pregnancy losses as well. So the interesting thing is, it is important to note that as the number of miscarriages will increase, the risk of euploid, normal pregnancy loss, will increase as well. Is it making sense? See, number of miscarriages are increasing, so the risk of normal pregnancy loss is also increasing after that. All right, now let's talk about anatomical factors. Okay, so we have discovered antiphospholipid, we have discovered genetic factors. Now we are going to cover anatomical risk factors. So what about anatomical risk factors? So anatomical risk factors would be, uterus. Okay, so we are going to talk about the prevalence of uterine anomalies in recurrent miscarriage population is 1.8% to as high as 37.6%. Interesting, isn't it? So it could be as low as 1.8 to as high as 37.6. For me, it is a huge number, isn't it? Because this is also most commonly overlooked, the kind of factor. Because usually when we come across with any kind of uterine anomaly, so sometimes, we cannot even, the deal with that anomaly. Sometimes we cannot even, the give our support in terms of even clinical, even psychological, or any kind of support to that, the woman. So women with arcuate uteri tend to miscarry more in the second trimester. It is, however, but it is occurring in the second trimester. Then the women with septate uterus are more likely to miscarry in the first trimester. S, very late alphabet in the, the alphabets, but it is occurring in the first trimester. All right. So these are, the sum of the Mullerian duct abnormalities. Yeah. So this is normal uterus. This is unicornuate uterus. This is uterine hypoplasia. This is septate uterus, in which we are having, the septum. It could be incomplete, it could be complete. Okay, we are not going to go into the detail. Yeah. So septate uterus, when there is going to be a septum, when there is going to be a uterine diadelphys, the two uteri, two cervices, the separate one. All right. So yes, we do see in our population as well, all these Mullerian duct abnormalities quite, the commonly. So septate uterus is going to be when the septum is going to come and divide the uterine fundus into two equal halves. It could be, the arcuate uterus as well, when there is going to be only, the dimple. Or sometimes we do say, this is going to be a heart-shaped uterus. Heart, okay? The heart-shaped uterus. So that is going to be arcuate uterus. So yeah, I mean, this could be, the less dangerous, but this could be very dangerous. And however, me myself have seen, the twins in both uteri, the uterine diadelphi, although, we had to terminate that pregnancy at 32 weeks of gestation because of, the multiple problems. But yeah, the both babies were alive, and the woman has had, the two uterus, two cervices separate completely. So yes, the clinical scenarios they happen as well. So make sure that in terms of recurrent pregnancy loss, you do have this in your mind as well when you are going to see your patient. All right. There could be uterine anomalies. There could be the chance of cervical weakness as well. All right. So what about cervical weakness? What is the normal length of cervix? It is for about 35 mm, isn't it? So if it is less than 35 mm, or clinically, if we are going to talk about, or if we are going to label somebody as, that this is, the labeled cervical weakness. All right. So we have to tell them that yes, it could be one of the leading cause of second trimester miscarriage, but not the first trimester miscarriage, recurrent miscarriage. So usually the diagnosis is based on history of a second trimester miscarriage, which is preceded by spontaneous rupture of membrane or painless cervical dilatation. Very, very typical, the history and the presentation of second trimester loss. All right. Women sometimes gives us history that, I was just sitting and somehow, I started having, this, the rupture of membranes and I never felt about that. Painless cervical dilatation. She might not be aware of cervical dilatation, and sometimes we do pick it on the the mid-trimester scan as well. So it all depends upon the reasons and all. Then this we have said earlier, endocrine risk factors, diabetes, thyroid. It has been associated with miscarriage, but well-controlled diabetes is treated. Thyroid dysfunction is not a risk factor for recurrent miscarriage. Both. It could be, however, the cause of, the sporadic miscarriage, the one-time miscarriage, but not the recurrent miscarriage. Polycystic ovary has been linked to an increased risk of miscarriage. Okay, because it is associated with insulin resistance, hyperinsulinemia, hyperandrogenemia. It will hamper, everything at the hormonal level. Infective agent, if we talk about, so torch screening. So please don't offer torch screening to the recurrent miscarriages. Okay, it could be one of the reason for the sporadic miscarriage. Okay, so what will happen is the presence of bacterial vaginosis, another infection. It is not going to be the risk factor for first trimester miscarriage. However, it could be the risk factor for second trimester miscarriage, which can lead to preterm birth, which has its own implications. So inherited thrombophilias, we have said that yes, it could be the possible cause of recurrent miscarriage and late pregnancy complications, with the presumed mechanism being thrombosis of the uteroplacental circulation. And we have said earlier that yes, it is the most commonly treatable cause of the in terms of recurrent miscarriage. So all women, let me repeat, all women with recurrent first trimester miscarriages and all women with one or more second trimester miscarriage should be screened before pregnancy for antiphospholipid antibodies. Okay, so I think this should be a take home message for every practitioner there is that yes, we need to understand the dynamic, we need to understand the risk factors and the pathophysiology of the miscarriages. Okay, so keep it in your mind that yes, inherited thrombophilias, okay, should be screened, and especially the antiphospholipid antibodies. We need to go for the 3 tests. Okay. Okay, so in terms of investigations, what do you think is going to be the most important? So yeah, we are going to evaluate every risk factor, and then we are going to give them investigations. All right. So there is going to be the investigation in the different guidance. So again, we are going to give the broad the overview. So generally, RCOG doesn't give the multiple the guideline. ASRM, it says that medical history related to recurrent pregnancy loss, okay, or the lifestyle. ISHR, the European guidelines says the medical, obstetrical, and family history is also important. We need to find out, the general causes. Then we are going to talk about the genetics. Yeah. So like I said earlier, RCOG endorse that you have to send product of conception of third subsequent pregnancy loss, third consecutive pregnancy loss. You have to send it for genetic analysis. So you are going to send that for genetic analysis, and you are going to see that if it is unbalanced structural chromosomal abnormality, then you are going to offer parental karyotyping. Okay, you have to send them for genetic analysis, parental. This ASRM also says that parental karyotyping is good, and it also says that product of conception may be useful as well. But European guideline, it doesn't endorse that, we don't have to do any parental, the karyotyping on a routine basis. Okay, then hereditary thrombophilia. RCOG says that only in women with second trimester loss. Antiphospholipid antibody syndrome. So we have said, yeah, lipid anti, the cardiolipin and anticardiolipin antibody, lupus anticoagulant. We have to do 2 occasions 12 weeks apart. ASRM also says that yes, you have to do the beta 2 glycoprotein 1 antibody as well. And European guideline also endorse it because this is a very important risk factor. However, it has been studied in almost all populations all around the globe. So yeah, they had been, endorsing this that yes, APS should be investigated in almost all causes of recurrent pregnancy losses. Endocrine, RCOG doesn't says, but yes, it endorsed that yes, the control should be adequate. For example, diabetes is very prevalent in our society. Thyroid is very prevalent in our society because both have autoimmune, the cause. So one autoimmune will not come alone. It will bring another brother or sister with. And usually diabetes is associated with, in half of the cases with thyroid. So yes, we can go for, the serum TSH as well. So SRM says that yes, TSH and hemoglobin A1C should be done. European guidelines says that yes, thyroid stimulating hormone, thyroid peroxidase antibody, we have to do it. All right. Then we have said earlier that yes, uterine causes are there. So first of all, we need to assess it from transvaginal scan. If we find out any kind of problem, and if the sonographer is the brilliant enough, and if the sonographer is giving us any kind of hint that there could be any kind of problem, so yeah, we have to assess it further with hysteroscopy, or either we have to go for 3D scan if we see that transvaginal scan is 2D transvaginal scan is abnormal. So the SRM says that yes, we can go for SHG and HSG or hysteroscopy, both. But European guidelines says it's better to go for 3D scan because that is more cost effective than the HCG and hysteroscopy. Male factor, RCOG doesn't says itself, but yes, sometimes the sperm, the morphological problem can also be there. Okay, it can be considered for explanatory purpose. However, it cannot be directly associated with immunological factors. Usually we don't consider that we have to go for any kind of study. Okay, so let me summarize again. So first of all, we have to take the detailed history. We have to do the general the perception in our mind that what could be the probable cause. Then we have to find out the genetics. If it is the third consecutive pregnancy loss, we have to send it for genetic analysis. And if on genetic analysis we do see it is unbalanced structural chromosomal abnormality, we are going to offer parents, the both parents, husband and wife, parental karyotyping. All right. The third is going to be hereditary thrombophilia. We have to find out, the APS, which is very important, and almost all guidelines around the globe, if they endorse. Then for the uterine anomaly, the very cost effective is going to be transvaginal scan, and it has to be done by the expert hands because of course, we need to see the affordability, we need to see the cost effectiveness as well. All right. So TBS, if on TBS we find out any kind of problem, then yes, we are going to go for hysteroscopy if the facilities are available, or either we can go for 3D scan as well. Again, everything is operator dependent. So make sure that you are choosing an expert operator for your patient to give the maximum benefit out of it. All right. Is it clear so far? Any question? Clear, everyone? All right. Now we have investigated, and now we are going to talk about the management. So of course, management is going to be directed towards cause. All right, isn't it? So management is going to be very much directed. So in management, first of all, don't be hesitant in calling the husband. Okay. So ideally for every counseling, the couple should be seen together, and they should be, they educated together as well, because this is not the loss of women only, this is the loss of couple, in fact. Okay, so in West, usually they say that we are pregnant, we are expecting. Okay, we are expecting a child, but in our society we do say, oh, that woman is pregnant. Okay, okay, I am pregnant. I'm having, this blah blah blah. Ideally, of course, a child belongs to both. So a couple should be seen together at a dedicated recurrent miscarriage clinic and given accurate information to facilitate the decision making about future pregnancies. So APLA should be considered for the treatment with low dose aspirin plus heparin to prevent further miscarriages. So what will happen is first pregnancy loss, second pregnancy loss, we can go for, we can consider from the second pregnancy loss if we think the age is high for the both partners. If we think the chances of chromosomal abnormalities can be high, because as a practitioner, as OBG, we are the best judge of our patients, isn't it? So we can send chromosomal analysis for product of conception. If there is aneuploidy, no further investigation. Okay, but if it is unbalanced chromosomal translocation, parental karyotyping. If it is normal, no, then we are going to go for full recurrent miscarriage workup. And what was that? We are going to take the detailed history. We are going to do the transvaginal scan. We are going to do the APS, completely. Then, or maybe we can go for, the productive conception studies as well. So the sporadic fetal chromosomal abnormality is the most common cause of a single miscarriage, what I have said earlier. That for first trimester miscarriage, it is the most common chromosomal, the problem. Okay. No, aspirin is from 12 weeks till birth. Okay. So please change this conception as well. 75 milligram aspirin is not going to do any kind of harm. So kindly don't stop the aspirin. Okay, because the last trimester is a very vulnerable period. If you are stopping at 36 weeks, have you guys ever seen that, the late trimester, I'm coming to aspirin, high dose aspirin. Usually we do give high dose aspirin. Let me come to that. Okay, so aspirin, first of all, Dr. Shams, we are going to give it from 12 weeks till birth. We are not going to stop. Why? Because the late onset preeclampsia is quite prevalent in our country. Maybe we don't see any risk factor, throughout, the antenatal period. But somehow when it is 36, 37 weeks, suddenly, boom, the blood pressure is, the skyrocketing. Yeah. Blood pressure is, skyrocketing and it is 200 by 110. We are upset. Our resident is upset. Our the attendee is very much upset. That what happened. So kindly do not stop 75 milligram aspirin. Okay, now coming to this Maria 150 milligram. So 150 milligram is going to be, for example, if your patient is of high BMI, more than 30 kilogram per meter square. Okay, high BMI, let's say, if her body weight in kilogram is more than 100. Okay, so yeah, 150 milligram. If you see that she is having pre-existing diabetes, pre-existing hypertension, pre-existing, the chronic renal disease, pre-existing anything. Okay, so yeah, you can consider 150 milligram. However, the role of 150 milligram and the 75 milligram is yet to be studied comparatively. Okay, so yeah, but we can consider. No guideline has clearly given us, any kind of indication that yes, we have to give. Okay, so according to your, the patient needs, according to, I must say that, if a patient is having chronic kidney disease, the type 1 diabetes mellitus, long-standing type 2 diabetes mellitus, long-standing, the hypertension, chronic hypertension, okay, or hypertension because of, the any other problem. All right. So in that scenario, yeah, you may consider 150 milligram. Okay. Now coming to when you have to stop it for 150 milligram, again, we don't have any clear guideline because we do follow guideline. Yeah. So we do follow guidelines. So we don't have any clear guidance for 150 milligram. So that's why if you take any guideline from any board, all right, so you are just going to be talking about, in UK or Europe, they say baby aspirin. 75 milligram is in, the UK, Ireland, and 60 milligram or 65 milligram is in the, the Europe. Okay, so they call it as baby aspirin. All right, so same because we still follow the British culture, isn't it? So in our country as well, so we do have 75 milligram. Okay, that comes with the name of Ascard. Okay, that comes with the name of Loprin as well. If we really want to give, the quoted one, so it all depends on. All right, so yeah. So we are going to treat them. So the risk of miscarriage as a result of fetal aneuploidy decreases with an increase in number of pregnancy loss. If the karyotype of the miscarried pregnancy is abnormal, there is a better prognosis for the next pregnancy. See, why? Because now we have said earlier, that fetal chromosomal abnormality is most commonly cause of single miscarriage. So if it was because of chromosomal miscarriage, so there are high chances that it is not going to be repeated. However, if it is the cause in terms of antiphospholipid antibody syndrome, then yes, the chances of recurrent pregnancy loss is there. Okay, so how we are going to deal with this antiphospholipid antibody? So the heparin we are going to give the aspirin. So aspirin again, before giving any medication, try to find out that are you allergic to any medication. This is a very important, the basic question you need to ask from every, the patient. Okay. According to BMI, how we do adjust? Actually, because we are not working in multidisciplinary team approach. Okay. However, the consensus is that even if you give 20, the mg, 20 mg for the low BMI patient, okay, so it is going to suffice. So in our the practice in our hospital, what we used to do was that we used to give either 40 milligram in one dose or 20 milligram in divided dose, okay, BD. So this is the, yes, we do have a protocol from RCOG guideline as a prophylactic and according to the BMI, or you can say according to the body weight. Okay, they calculate according to the body weight. All right. So if you guys are interested, I will share that with you as well in your that group. So you guys can do that. But otherwise, I will suggest that take an opinion from your the medical specialist as well. Okay. Yeah, definitely I'll share. But apart from that, take a opinion, single opinion. Even if you are in low resource, the setup anywhere. So at least you will be having, any friend across, you can talk, you can, take an opinion. All right. And still, we are open. I am there, there are so many fabulous colleagues in this, the group. Okay. So you guys can always, ask and we will be offering our extended help. All right. So heparin, if we are offering heparin, so of course we have to counsel them for bleeding, hypersensitivity reaction, heparin-induced thrombocytopenia, but this is like, I mean, in a very high dose and in a very, the long-term process. And in the long-term use, osteopenia, vertebral fractures as well. So, all these are going to be very much associated, but yeah, we need to be very much, careful. So, the low molecular weight heparin mostly comes in our, the setup in our, the most of the countries it is glycine, okay, and sometimes they do give in different the strength. Like I said that we can give 20 milligram in the BD dose, or we can give 40 milligram as well. So it all depends on. Okay. Before heparin, which investigation? This is the beauty of heparin, that if you feel that there is no risk factor, so even monitoring is not required. Okay, and even if you really want to be safe, then I would rather say that go for full blood count, especially, and note down platelet. Baseline platelet level is very important. I would never suggest to go for extended studies for PTA PTT, because that is the costly as well. So we need to see the patient, we need to see the pocket of patients as well. All right. So baseline platelets are very much important. Okay. Okay. Brilliant. All right. So now let's conclude what we have they discussed so far. So we have said that okay, we need to the recommend chromosomal abnormalities if we really think that we are going to go for their chromosomal analysis. Okay. Then we are going to no PTA PTT no. PTA, PTT, this is the beauty of heparin, Dr. Shams. Let me tell you that, we don't have to monitor heparin, low molecular weight heparin. But yes, if you are offering unfractionated heparin, remember we used to have, the vials. In that scenario, then yes, you have to do. But in low molecular weight heparin, we don't need to do, because it is low molecular. It is not going to cause, the problems with unfractionated heparin, because we are using fractionated. Okay. All right. So if there is an anatomical problem, so yes, if it is septate uterus, if there is any kind of septum or anything, it is pretty much safe for mother. It is pretty much safe for baby as well. All right. So don't worry. If even if you feel that your patient is having APS, or if you want to give as a trial, even if to your the patient, sometimes, we have to look at the clinical picture as well. All right. So sometimes in our setting, we do give it a try. So yes, people do respond, patients do respond, because every patient is different. All right. Okay. So if there is any surgical, the correction is needed for any uterine abnormality, then yes, we can go for that. For thrombophilia, we can go for unfractionated heparin. Okay. So in terms of unfractionated heparin, always remember, all of you guys, unfractionated heparin needs monitoring. Unfractionated heparin needs, the proper dose adjustment. Okay. So the patient is going to be admitted, and in the usually unfractionated heparin is going to be in the acute event. If there is any acute, the BTE, acute pulmonary embolism, if you have to treat it, then you are going to give it. Low molecular weight heparin most of the time is prophylactic. Okay, like in APS, like in hemophilia, we have been, the giving this low molecular weight heparin as a prophylactic, the treatment. Low dose aspirin for APS. Infection, infection plus minus if it is because of an infective agent. So yeah, we can consider antibiotics. If it is immunological factor, no, nothing is there. Okay, so no evidence of use we are going to discuss in the end. Endocrinological, for example, if a woman is having diabetes, thyroid, hyperprolactinemia, so treat the cause, not the symptom. All right. So if it is diabetes, okay, treat the diabetes accordingly. If it is type 1, if it is type 2, like I said earlier, that one autoimmune is not going to be without any other autoimmune. So please, please, please make it a habit that if a woman is diabetic, go for TSH as well. And in pregnancy, if you are going for, the go for free T3, free T4, not the serum one. Okay. Because in pregnancy, the hormonal balance and the imbalance is completely changed. All right. So if there is any hyperprolactinemia, so yes, we have to treat it, because hyperprolactinemia is not going to let any GnRH release from the hypothalamus. So already woman is going to be compromised. So treat hyperprolactinemia, not the ovulation, not the fertility, because the cause is there. Male factor. So yeah, lifestyle modification. We can give antioxidants. Okay, we can give some antioxidants. There are, the trends going on these days. What are the antioxidants? At vitamin level, we say, the A, C, E, we see the zinc, we see vitamin C. Okay, these are proper antioxidants. So yeah, the newer studies have shown that, the sperm parameters can be deranged because of the oxidative stress. So you have to reduce that oxidative stress, because oxidative stress is going to be at the cellular level. So it will hamper the spermatogenesis. So you need to decrease. So yeah, it can be helpful. It cannot be helpful. Maybe, because still evidence is lacking. Okay. So we can give vitamin A, vitamin C, vitamin E, zinc, and vitamin C as well. And currently there are studies going on selenium as well, because this is also powerful antioxidant. All right. So if it is unexplained, in unexplained, where you do not find any of the cause, but still woman has had 3 consecutive, the miscarriages. So in that scenario, progesterone has a role. Please don't stuff any miscarriage woman with progesterone. Kindly. Okay. This is going to be my humble request to everyone. Don't the put every woman on progesterone. Progesterone has its own side effect on the fetus, on the mother as well, both. Because the most common side effect of progesterone is water retention. That water retention can lead to the hypertension later on. You must have seen, or you may recall, some of your patients that who has been treated with progesterone in the first trimester. Sometimes they have been stuffed with, the dydrogesterone. Sometimes they have been stuffed with, the graviminone injection, in which there is a very separate form of progesterone. I think 11, 17, beta hydroxycaproate, something like that. Okay. So don't stuff any woman with progesterone. So what will happen is that it will increase the water retention. It will lead to hypertension later on. Patient will present as torrential, the problems, severe preeclampsia, abruption, IUGR. And you will be thinking, okay, what could be the probable cause? The cause could be, the this progesterone, which we have been giving our patients. So trust me, there is no role of progesterone until and unless you have there is a spot in the early pregnancy, and I have seen, so many prescriptions with, the oral progesterone, injectable progesterone. Trust me, this is a crime. You are not helping the woman. You are doing a crime to the unborn fetus. because all these progesterone, some of the progesterone, if they are not properly synthetically made, so what they can do is they can do androgenization of female fetus. So can you imagine that, what type of stress we are giving to unborn fetus? Androgenization of female fetus. Okay. So please be extremely careful. However, it has a role in unexplained, the recurrent pregnancy loss. It has a role in the second trimester loss as well. That is a very separate topic. Okay. So generally, how you are going to advise your patients: maintain normal BMI, stop smoking, take vitamin D, okay, and go to the dedicated recurrent pregnancy clinic, because in our society we don't seem to have any dedicated recurrent pregnancy loss clinic. So this job we can give to our patients, isn't it? So we can extend our help, we can talk to them, we can give them bereavement counseling, we can sit with them, we can talk to them, okay, we can let them open their heart. All right. So it is going to give the very positive impact to the patient as well, that yes, this doctor is with us, she is feeling our pain. Okay. And trust me, if you build that trust to your patients, so that this patient is not going to go anywhere, because if this lady is suffering from 3 consecutive losses, so she needs an alive issue later on, isn't it? So make sure that we are practicing in a way that we are being beneficial, rather than we are being the cruel, not cruel in the sense of the openly cruel, but yes, maybe unintentionally. All right. So there is no role of, no evidence of surgical treatment to any of the Mullerian abnormalities, any treatment of the congenital thrombophilia, and the prophylactic antibiotic, prednisolone, IVIG, intralipid, treatment of subclinical hypothyroidism, in which TSH is normal, but T3, T4 is normal, but TSH is raised, or any thyroid peroxidase antibodies, any androgens or any HCG, no role. Don't stuff your patients with anything unless until it is indicated. So yeah, this was left caffeine. Okay. So for the caffeine, we can limit less than or equal to 3 cups a day. Caffeine could be, the pure coffee, or it can be in the form of tea as well. All right. So we have to ask them, limit their caffeine, because again, caffeine could be harmful or disastrous at cellular level, maybe because it can act as oxidant. All right. So it can damage some of the cells, some of the new forming cells, or maybe you know there are still the studies going on. They say that the caffeine can hamper implantation as well, because what will happen is that there is going to be defective, the placental formation, defective, the endometrium formation as well. Receptivity will be decreased. So yeah, we need more studies. But yes, it is very much logical, it is very much advisable that limit caffeine in less than or equal to 3 cups a day. Then chromosomal abnormality, then yes, we can go for that. Anatomical abnormalities, we can go for example, if there is fibroid, if there is anything. So yeah, we can go for thrombophilia, we can go for infection, we have said immunological, endocrinological, male factor, we have said unexplained, we have said general, we have said. All right. Clear, everyone? Any questions? So this was all about recurrent pregnancy loss. So from my side, the take-home message is going to be: do try to, talk to your patients. Do try to take a detailed history, and make sure that you are making a clear, the definition of recurrent pregnancy loss. That it is more than 3 consecutive pregnancy losses, 3 or more consecutive pregnancy losses in less than 24 weeks of gestation. All right. And make sure that you are keeping your antiphospholipid antibody syndrome as the prime suspect. Okay. So if you feel that your patient cannot afford heparin, so at least put the patient on aspirin. Okay. We can give at least. And when you have to start, this is a clinical tip. So let me just give you can start aspirin once, UPT is positive, urine pregnancy test is positive. Doesn't matter beta HCG, because that is again, the costly, right? When UPT is positive, you can start aspirin. You can start heparin, low molecular heparin, once cardiac activity is evident on scan. Okay. So this is a clinical tip. And for aspirin, I have said earlier that you have to start, in confirmed APLA, you are going to start from UPT positive. But if you feel that, there was a history of, the early onset IUGR, okay, early onset preeclampsia, early onset abruption, less than 24 weeks of gestation. In that scenario, you are going to start from 12 weeks of gestation because you have to, the stop the second wave of trophoblastic invasion that is going to start from 18 to 20 and complete from 20 weeks. Okay, those are going to make the vessels, the broad flow is going to be good, everything is going to be good in the end. All right, but for the APLA, okay, this is our strategy for IUGR abruption and the preeclampsia toxemia. The strategy is going to be pretty different. All right. So the sources I have taken for this particular, the presentation, Green Top Guideline on recurrent miscarriage, and there is a talk article on recurrent miscarriage as well. If anybody is interested in learning, the yourself, so I can send it on your, the WhatsApp group as well. Clear, everyone? Any question?
Doctor, I have a question. If
Mm-hmm.
you could hear me, please.
Yes, yes, I can.
First of all, I'd like to thank you. It was really very helpful and informative.
Thank
My
you.
question basically has two parts, Doctor.
Mm-hmm.
One is that if you are practicing in a periphery where you don't
Mm-hmm.
have that facilities and your patients are not, they are not of that socioeconomic
Mm-hmm.
state
Mm-hmm.
can afford the karyotyping or the rest of the
Mm-hmm.
other investigations.
Mm-hmm. Mm-hmm.
What is the role of aspirin if you give it without going for APLA? Can you give it on the basis of just
Yes.
like history?
Yes.
If a
Sweetheart,
patient is,
what you can do is that, at least, you have taken, that's what I said. Try
yeah,
talking to your patient. All right. So try talking to your patient. You have found out that, okay, there is more than a requisite 3 consecutive miscarriages. Okay. So, I mean, this could be, this cannot be. All right. So, because we don't have any product of conception, I very well agree with you. Okay. So, what we will do is that, okay, keeping in view, then you will take, the family history as well. Because in APLA, or because it is acquired hemophilia, right? So sometimes we need to ask from other as well that is there any history of the clots in the family, okay, in the legs or lung. So sometimes they do give, sometimes that yes, the flan that died because of she had a clot. Okay, sometimes they do give. If they don't, then yes, aspirin is, let me tell you, don't be afraid of aspirin, trust me. Aspirin is a lifesaver. Okay, so aspirin is a lifesaver for your patients if you are in low resource areas. So yes, go for it. Don't hesitate. It is
okay,
not going to change your any practice. It is not going to do any harm. Trust me, 75 milligram, like I said earlier, this is baby aspirin. All right, this is
yes.
baby.
And the
So you
second
can you
part,
can start it. Yes, please.
yes, and the second part is, doctor, if like I've seen it in the recent time that it's been very common that girls of young age coming with a history of irregular
Mm-hmm.
cycle without having that mm, high BMI or hirsutism or acne, but there is a history of like irregular cycle, may that be oligomenorrhea or scanty menstruation
Mm-hmm.
or painful cycles or irregular cycle, like getting periods for one
Mm-hmm.
cycle and then there is a miss of 3 cycles and then again for 2 consecutive cycles they are regular, again
Mm-hmm.
they miss for the next three
Mm-hmm.
months.
Mm-hmm.
So if like a girl comes to you, she's been married for 2 to 3 years and she has this one or two miscarriages and
Mm-hmm.
she gives you this vague history like I get my cycle on time, but there is only a spot on day one or spot on day two and I have the scanty menstruation. Is there any role of glucophage that we can offer her in order to conceive or in
Okay,
order in
very
combination with
interesting
aspirin?
question. So now we have I have taken down I have broken down into two things. We have one terminology, scanty periods, we have irregular or we have infrequent. All right. So the two
Yes,
terminologies are there, right? So now let me tell you, let's break it down into two parts. Scanty periods in our society, where tuberculosis is very common. So try to find out, the family history of tuberculosis first of all. Okay. So just take a history. That is there any family history of tuberculosis in you, or have you ever been treated for the tuberculosis or no? Ever? Okay, so scanty period could be one of the reason with the tuberculosis. Number one. Secondly, irregular and infrequent periods. They are associated with again polycystic ovaries. Okay, coming to your question again, that your patient is very thin lean. And the interesting part in polycystic ovaries, 40% are thin, lean women.
Yes,
Okay,
very
so
much.
never, so never
Very much
think
agree.
that every PCO is going to be the obese.
Yes,
No,
and it is
okay,
otherwise
so
also,
yeah.
sorry to cut you, but you go for the investigations and you don't get any evidence of this.
Yes.
It goes
Okay.
on
Now let
the
me tell you the
and
beauty of
on the
oral hypoglycemic agent. What is the beauty of oral hypoglycemic agent? They are going to work at, at the level of insulin, at the level of, because they are going to desensitize, okay, the ovaries. All right. They are going to decrease the insulin level. They are not going to act on, the sugars. So please, kill this misconception as well that with oral hypoglycemic agent, there is going to be hypoglycemia. So we cannot give it to the low BMI. Plus another misconception. Many patients come to us, Dr. Saab, this is for weight reduction. Oh, come on. We have to kill this conception as well. That this is not designed for, what I tell it to my patients. I say that, have you ever seen Panadol, paracetamol? So she says yes. I said, okay, I have a headache, I have a backache, I have, the joint ache, the knee joint. So do you think that I have to take a separate Panadol for headache, separate Panadol for backache, separate Panadol for, the joint pain? So she thinks for a while and then she says, no. Then I say that yes, this is the answer. This is the logic for glucophage or, the Nudipar. That yes, it is not designed for only, the diabetes. It is not
type
designed for weight loss at all. It is designed for, decreasing the level of insulin. Because
insulin.
I say that, and another beauty is that if we give, the oral hypoglycemic agent properly, it is not going to affect weight as well. You know that if we ask them to have a balanced diet, and if we give them, the oral hypoglycemic agent, it is not going to affect weight as well. Trust me, maybe 1 kg or 2 kg, but not more than that. But yes, in obesity, it has a drastic, the role, because in obesity, it is going to act peripherally as well on the fat cells. It is going to desensitize insulin. You got my point? Hmm?
Yes,
So yes,
doctor.
please feel free to give insulin. Please free this oral hypoglycemic agent. Please don't hesitate on giving aspirin as well. All right.
Because I got it to one of my patient,
Mm-hmm.
and she was like the same response that this is a drug for the diabetics, or my scan is fine and my lab investigations. Why are you offering? So I told her, trust me, there's a little difference between me and Google. That Google can't read all the books, and
No,
we should
trust me,
do
we
that.
can't teach our, the patients these days because everybody is doctor. Everybody is
Yes,
Google doctor. Everybody
Google.
is doctor from Facebook as well. If you see from
Yes,
Facebook, there is a post on Facebook, my baby is having this problem. So what could be the reason? Oh, come on, go to the doctor. Don't ask from the woman. And there is a whole thread that this could be because of that, because I had this, because my son had this, my blah, blah, blah. Okay. So please take my, the example, the same example for the Panadol. Okay, do we have, the separate Panadol for separate pain? No. Okay. So we have this glucophage for so many, the reasons as well. So please don't hesitate to sum up. Don't hesitate to give it to the thin lean patients as well. Okay. If you even give these days, there is a new glucophage as glucophage XR, which is coated, which comes as 750 milligram. So if you give to the obese woman as the bis a day, the twice a day, it will give the drastic result to your patients, and you can have the ovulation, return of ovulation in 3 months, and maybe the positive pregnancy test in upcoming 6 months. This I have seen in my own patients as well.
yes,
Alhamdulillah.
sir. Thank
Okay,
you.
so there is a 750 milligram. This is termed as, this is comes as a name glucophage XR. Okay,
Next,
it is a
yes,
sustained release 750 milligram. If you give in obesity, as twice a day for 3 months, it will give the very good result. If you want to give for your thin lean patient, so you can give it in combination, because at least we have to give 1,000 milligram. All right, so you
right,
can give 750 milligram one and the 500 milligram the normal one. So I
the
would
normal.
suggest, go for it, go for it. Don't hesitate. Okay.
Thank you, doctor. Thank you so very much. Thank you.
Welcome, welcome, welcome. Very interesting question. Okay, brilliant. Any other question? Mm-hmm. Thank you, Maria. Thank you so much. Thank you so much. All right. Thank you, sweetheart. Okay, so I hope we don't have any question. So still, if you guys have any question, you guys can write it down in the WhatsApp group as well. We will try to help. If, even if you have any clinical, the study clinical case, if you want our opinion, so yes, we will be happy to extend our help. All right. Thank you, Huma. Thank you so
Thank
much.
you very much, Dr. Zaib, for the lovely session. I really enjoyed, and I'm sure that everyone has enjoyed and
Thank you
must
so
have
much for
taken
giving me the
something.
chance.
Yeah, that's very good. Everybody, I'm getting actually the messages of appreciation. So
Oh, thank you
thank
so
you
much.
very
Thank you
much.
so much. I hope I was helpful. So I hope we get a take-home message as well, right? So from today
Sure.
onwards, we're not going to hesitate for the aspirin. We're not going to hesitate for the oral hypoglycemic, okay, the glucophage and the nudipar. And we are going to, talk to our patients. We are going to extend our help. We are going to give our bereavement counseling, all right? And plus, please, please, please don't forget that, we have to, they do the APLA, okay, because APLA is very prevalent. All
Exactly.
right. Okay. Thank you so much. Thank you
Thank
so
you
much
very
for
much.
thank you so
Thank
much for
you.
wonderful participation, guys. Thank you so much. Take good care of yourself and your loved ones. Bye bye. Allah Hafiz. Thank you.